we are bottom centers.
Right. Good morning. It is Wednesday, January 25th, and this is the Senate Health and Welfare Committee. We're meeting this morning with an introduction to the new CEO of the University of Vermont Health Network. So I'm going to let you introduce yourself in just a minute. Before that, we'll go around the table and have folks introduce themselves. And Senator Gulick, why don't you?
Hi, I'm Senator Martine LaRoche. I live in Burlington and I represent Chittenden Central. Nice to meet you.
Good morning, Dave Weeks, representing Rutland County, and I come from Brockton.
Ginny Lyons, I represent Chittenden Southeast and live in Williston.
Terry Williams, representing Rutland County, and I'm from Polk.
Ruth Hardy from the Addison District. I represent Porter Medical Center, basically. There you go.
Well, that's a good way to do it. All right. Okay, so, it's a pleasure to have you here, and we do a great deal of work with our hospitals across the state, and right now we understand some of the significant issues related to the role that you're playing, but it would be great if you could just introduce yourself for the record first, and then talk a little bit about who you are and what your work will be at the medical center, and then we'll go from there and ask some questions.
Great. So for the record, I'm Sonny Ethan, President CEO of the UVM Health Network. I thought I would just, again, start with a quick overview, probably good for all of us to just ground, but we have 8 affiliates that you're probably familiar with, but including Porter Medical Center in Middlebury, but we have Central Vermont Medical Center in Berlin, the University of Vermont Medical Center, which is our academic medical center in Burlington, which serves really as our tertiary primary referral center, but also is the community hospital for Chittenden and Grand Isle counties. The University of Vermont Health Network Health and Home Health and Hospice Center that also serves Chittenden and Grand Isle counties, as well as our network. Then we have Central Valley Physicians Hospital in Plattsburgh, New York, Alice High Medical Center in Malone, the University of Vermont Medical Group, which is a standalone group right now, and the Elizabethtown Hospital, which includes the Ticonderoga campus, which used to be a hospital that innovatively has been converted to a 24-hour emergency department and outpatient clinic, and that's been quite successful as well. I think Jason has provided fact sheets on all of them. I can see you're looking through it, Senator Gulick, already. Everyone's got that, which is great. Just to go back a decade probably as we started to form our network, really piecemeal, hospital by hospital coming together. But the feeling is the hospitals joined, willingly joined, and became affiliates, and now we call them partners. It's because we recognize that if we were going to actually leverage the network in a meaningful way to provide care across all of the patients, this was really the only way to do it. That we had to take the best of each of these hospitals, decide, and this is still the process that's going on, and decide where should we provide certain services so that we can allow for patients to be as close to home as possible when that was appropriate, but then also leverage the network so that we can move as needed. We need to do more of that. Just to give you a little bit of background about myself, and some of it may be repetitious to people that may have heard pieces of it, but I was born and raised in Chicago. My dad's a pediatrician. My mom was a stay-at-home mom, first generation immigrant. He worked really hard, just quite frankly discouraged me from going into medicine because the work was so hard, I thought. But I sort of wandered into that after getting a math computer science degree at the University of Illinois, and then went to the University of Chicago. I met my wife freshman year of college. We got married between 3rd and 4th year. I was 17 years old when I met her. We've been married for 32 years now. We have 3 kids, 28, 24, 22, all in various parts of their education, and they're all going to be in medicine in one way or the other, including my youngest, who's going to be a social worker, I think. I started off my career in Boston. My wife and I both came out to Boston to do our residencies. She's an ophthalmologist. I'm an anesthesiologist. Our plan was to be there for 3 to 5 years. I was going to be an academic physician. I spent the first 3 years of my career after I finished in a basic science lab decided that wasn't for me. I have 3 kids. I have a son that died early on, was sort of greatly shaped our lives. I stayed at home for 6 years and job shared with my wife. She worked 2 days a week. I worked 3 days a week. Really shaped and formed sort of an understanding of what it meant to be a stay-at-home mom, actually. And I was part of the part-time community at the Brigham, which was me and 29 women at the time. And it's completely shaped the way I think about childcare, the stuff that working women have to do, and it's also informed the way I think about diversity and inclusion in the way that we think about in our hospitals and care. I progressively, as my kids got a little bit older in school and we went back to work, progressively became more and more administratively involved. And in that Boston area, in the Partners Health System, National Brigham, my entire career, ending with being the chief medical officer at the Brigham Women's Hospital and the interim president there for about 10 months when our president there left. It sort of shaped the idea that, number one, I could do the job, that it was exciting, and the opportunity to influence a large community of providers and patients in a way that was there. I've maintained my style, which is a very much of a servant leader, the way I think what you guys are doing of representing your constituents. That's exactly my role. My job is to move obstacles out of the way, bring people together, get them to function at the highest level possible, surround myself with really smart people to be able to do that. Really motivated to come here because philosophically, this is what I think of. Vermont is what I think of as the model for our country in the way that we need to be able to deliver care. That is, cover everyone, deliver care equitably, change the model of how we think about healthcare in America from taking care of people getting sick, but rather to keep them healthy. And then when they do get sick, wrap around all the services that we need to provide. That's what we're looking to try to do. And we're committed to doing that in partnership with all of you, because we can't do it any other way. And so I'm excited about that. I can go into some details. I mean, we're losing money. We lost money last year. We're heading in a path to lose even more money this year that we have to change. And it's not sustainable for us if we want to do the best for our community, our staff, our providers. We can't go down a path of continuing to lose money. And it's not the right thing to do for our patients. So that's where I find myself here. There's probably more things I'm supposed to say, but
we'll
you can push me on that.
We'll get there.
So.
But thank you for that. And one of the things that has always concerned me, and I think many of us, is that historically physicians are trained to look at pathology rather than wellness, and so Vermont has really, over the past 20 or so years, made that shift to looking at the whole person, community health teams that we have, and Blueprint and so on. And it's great to know that you're on board with that, because that's the direction I think most of us would like to be going. But maybe we could just go back and talk a little bit about some of the facilities and organizations that you have in your network. And I will say that I had my significant other had an interesting experience at Ticonderoga this fall. Thank heavens, having met up with a chainsaw. But without having Ticonderoga there, it would have been a real problem because it was in late evening. So maybe you could talk a little bit about the Ticonderoga facility and what it does.
So again, relatively new to me, and so I have to be a little bit careful. But the idea there, though, I think you got the idea there, which is it's understanding that the community needed a place that they could go to that would be available to them 24 hours a day, but that it didn't need to be a hospital to be able to provide that. And to get the mindset, which is really hard for that community that have gotten used to the idea, we've got a hospital right here. And can we provide the essential services that they need without it being a hospital, which has a very costly infrastructure? And then use the network as you need to, if you need to move patients out of there. And so we've also, as a part of that plan, we've invested in that regional transport service as well, which is critical to making these kinds of things work. And as that was crumbling, we knew that we needed to do that as our organization. And so putting that into place so that you have the pieces of being both available there for that immediate care, maybe, I don't know the details of
It was immediate care.
Yeah, But then also moving the patients as they need to our resources that are appropriate and doing it quickly, whether that's by ambulance, by helicopter, whatever needs to be done, right?
So it used to be called the Moses Ludington, I think. It
Yeah.
just came back to me, but now it's called, what is the name of it? It's the Ticonderoga
I don't,
Immediate
It's the
Care.
Ticonderoga campus of Elizabethtown.
That's it, okay, yeah, it's right there. Cool. And so the other question I guess I would ask you to maybe respond to a little bit is the relationship that the hospital network has with community services, including, like Washington County Mental Health or Howard Center and those affiliations with substance use disorder, mental health, and what you're looking at or thinking about going forward.
so there, I guess I would say there's two pieces. One is on the broader question of mental health and how we need to take care of that. Our plan is really to embed mental health right into the primary care facilities so that it just becomes, a part of the care that everyone receives and it's immediately accessible. That's the place where it needs to be. It doesn't necessarily need to be a psychiatrist, it could be a psychologist, a social worker that could provide that, but we need to embed that in a way that makes sense. And I think you do that proportionally depending on the number of patients that are there. It could be a day a week, 5 days a week. On the other folks like the Howard Center, I've had one meeting with the entire group where everyone came together, and we know that we need to better coordinate the care across all of those. I don't know what we call them, the DAs across our organization. And I've reached out to Rob Altoff, who's the head of psychiatry for our service, and connected with Secretary Samuelson, Jenny, around how do we best do this work in a really coordinated way beyond our health network, but across the whole state in a way to do this. We know we can't do that alone. So we have to come up with a sustainable model, but it's got to be more integrated in the way that we do that. And so everyone knows that what your resources are that are available to you, and who you need to go to. And so creating that network and actually kind of from what I understand is that we have really well-meaning organizations that do great work, but they're not connected in a way that would make sense for the whole state. And we can come up with the expertise and the planning, because I think we have that, but we can't do that without the state's sort of support and help to coordinate across beyond our network to do that. So I know it's a very high level. We probably need to talk a lot more about that in order to make that happen. But we've sort of literally given her the one pager and said, we'd love to develop this with you and with our state to be able to do this. And we'll see where it goes.
Yeah, no, that's great. I know we've been talking a lot about care coordination in this building and connecting acute care with subacute and how do we get people into the counseling services that they need. So it's nice to know that you're working on that at the higher level, and that's where it can start there. And I think a number of folks are interested in that. Can I ask you a difficult question? So one of the concerns that we hear about from constituents is how well financed and how powerful your network is. And yet when we talk with you, we get this perspective of caring and service. So how do you balance you're new, so it's hard for you to answer this question, that's why it's difficult. But to think about that, how do you balance those competing perspectives?
Tell me what the competing perspectives are again.
Well, that there are folks in the community who believe that the medical center, especially the one on top of the hill, is very well off and extremely powerful and monopolistic.
I see.
That's one, just to put it very bluntly.
Yeah, no, that's great. Now I understand. So to me, it isn't, there isn't a competing interest there. And so because I hope you saw that today in the way that our president spoke, but when you see, and I walk around, and this is my plan to continue to do this, I walk around in each of those hospitals, in the emergency rooms, in the med-surg wards, in the operating rooms, in the labor and delivery suites, is that the caring is just, it's overflowing. Because the caring comes down at the level of the provider and the patient. And there's just absolutely no doubt that every one of our providers cares, and they care deeply about their patients and their communities, and they want to do the right thing. That is independent of anything else that I think that you're pointing to. The University of Vermont Medical Center, in and of itself, is an incredibly special place that we need to utilize, and I think that we feel like we utilize appropriately to deliver the highly specialized care, to train our future physicians, nurses, caregivers. And that has a special place in the organization. And it is special in our state because that is really the only place that's doing that. But I think that and this is part of the work that I need to do, is that we need to work with everybody, and everyone should feel like it's their resource, regardless of whether you're in our network or not. And maybe we can do better about that. The other part is that we need to make sure that when patients ask or providers ask to come there, that we provide that service and then we send them back to their communities. That is our intent. And if that isn't happening, and so people feel like, we're gobbling up, we do not need any more patients.
We heard that this morning.
Yeah, we do not need any more patients. What we actually need to do, even within our network, is to move the patients that are appropriate to get care in other of our networks or otherwise, we need to move them there. So that we can really focus on the specialized care, the educational opportunities that are there. So that's the work that we need to do. And we haven't done that well yet. And I think we can do more on that. And so maybe that will help with that. It's hard for me to speak to the, I think the arrogance of that financially. I certainly don't feel what you're describing, which is, the dollars that come in and the margin that we build, we're building it so that we can reinvest so that our communities, our patients, can get what they deserve, both in the physical structure, but in the expertise that we need to compete with to be able to bring that here. So I'm not sure about the resources. I mean, it's big, but it's big, and that's
It's a
positive
perception
thing.
that's in the community. I mean,
Yeah.
it's not a personal perception, but it is something that we hear about in the community a lot.
But we need to do work to take that apart, and so we'll work on that.
Thank you. Other questions for Dr. Ethan?
If I could, we had a quick conversation about the labor force prior to the meeting kicking off this morning. And I'm curious, given the power of your organization and your excellent reputation, what type of levers are you potentially able to pull with our to look at the option of bringing in international labor as a gap filler, not necessarily long-term presence, but at least as a gap filler, and using all of the same criteria you would use for any new hire. Just kind of wondering why that isn't, why we're not reading about that in the paper as, okay, we've notified the congressional delegation and we've got a solution. It's 6 months out, what have you, but it's a solution for an immediate need. What's inhibiting that conversation?
So I'll start at the highest level. I've spent a lot of time with the American Society of Anesthesiology, just looking at the anesthesia workforce and the CRNA workforce, but it's a model for everything else that you're talking about, Senator. So I'll just think about that. So there's a huge shortage of anesthesiologists and anesthesia care providers in America. And one possible solution is let's go to Congress, let's open up the immigration laws to allow people to come in. That's piece one. Piece two is that we have to change the way that the American Board of Anesthesiology allows for people to work here and bill, which is not and this is for every medical specialty, which is not a trivial piece. And there's a bit of control and lobbying that goes into that. But there's actually a higher level philosophical issue that we have to battle with, which is, should we actually drain the resources of these other countries to bring them here? And is that the right thing to do? Because we're looking at that global population. It isn't like there's an excess of physicians everywhere out there, but we can still tap into this in a little bit of a function. And so there is an opportunity there. And then if you look at the collective bargaining units and how they would feel about flooding whatever collective bargaining unit that you have with additional folks, I can tell you, there is a difference of opinion about how to do that. Even if we can assure folks that the quality is really good and high and can maintain the same levels and standards, that's a challenge that we would have to overcome. So it's not trivial, it's not easy to do it. New York State, starting in January, has allowed for physicians to travel in without and they're going to ease the immigration rates and immigration issues. There's an exemption to allow that to happen, to come in. And the board, meaning that the Board of Medicine there has made it easy and facilitated their licensing. So there are steps that we could take. I don't think Vermont has done that as far as I know to make that easy. But New York has done that because they've seen that crisis and they've done it. It's targeting Canada largely, but it actually is open to any country the way that they've structured it. So there's an opportunity there, but there's a lot of work to be able to get there to bring folks in. And as you know, there's a pretty strong anti-immigration sentiment that is not, it's a federal issue more than a state issue to be able to do it. But we're not opposed to it. Yeah. If we could figure out the right way to do it. And the most successful, I'll stop talking, the most successful ways that people have done this is to actually partner with very specific college or colleges, like a nursing school, and say that, we're going to actually send people, work with your nurses that are there so that they're at the standards that we feel comfortable with, ease them into the exam so that they can actually get the practice of what that would look like, even if they're completely competent. It's a very different structure, and to be able to familiarize, you have to really do that and invest in those kind of partnerships, and then allow for them to have that immigration opportunity to come in and do that. So it's not easy. I mean, you probably know more about it than I do, but it's not trivial to be able to do that across international lines to do it. So it's a long-term possibility.
Okay, Senator Bullock, and then.
Can I just follow up on
Oh,
what,
sure.
and then,
Okay.
because this came up yesterday, and thank you for the answer, because it's consistent with what I said, actually. But there was a little working group of us last year that was working on this issue related to nurses, and could we find a way to get nurses from Mexico or some other country that's close by, Canada, to come to the United States. And after working on it for a couple months, in addition to everything else we were doing, we realized it was super complicated, and what we ended up asking for was a position in the budget at the Agency of Human Services that would, among other things, work on issues like this, the workforce issues more broadly. So that position is
It's there.
it's not there yet. I think they're advertising for it, but just to, for a bookmark for you guys to know that that's part of what that position was intended for.
That would be great. And if that actually takes a step, I think it'd be really important to make sure that we have nursing representation from one of our unions that would participate early on with that. And then there are a couple of countries, honestly, that make it quite easy.
Yeah.
The Philippines, India, the language skills are there, which is a huge barrier if you go to a non-English country.
That was one of the barriers.
Yeah. And so, no, that's fantastic. We would love to have that conversation.
Yeah, the person hasn't been
And-
hired yet, but I think it's embedded in all the work that they're doing on workforce at AHS. So
Right, passing the test, bottom line.
yes, I learned a lot more about like the NCLEX.
Oh, I know.
things.
There's a lot of them.
Yes.
Okay.
I just want to start by saying thank you for grounding us in your personal story. I really found that inspiring, and it's a nice way to start the work. So I have a kid at UVM studying molecular genetics, and I'm wondering, he's kind of interested in medicine, and I'm wondering, as an organization that's right next door, actually there, and I know you're separate entities, but I'm wondering what you're doing to sort of educate students, because you've got thousands of young adults right there who could potentially join your staff. Is there a connection? Is there any kind of outreach that's happening?
So we haven't done as much with the undergraduates. We are completely connected to the medical school, the medical students, and the nursing school and health sciences. And we've actually gone, and we are going further. This is the work that's happening right now with a very early path to grab particularly the nursing students, to say, and the respiratory therapists and the occupational therapists, physical therapists, to say, there's a really great opportunity and career here within our network and a great place to live. And so we're connecting very early with them. That's the plan, to be able to grab promising students that are here. We do quite well, but not as well as we can with keeping the medical students. The undergraduate piece is actually really interesting because both on the nursing side and on the medical school side, we continue to have the highest number of applicants to medical schools with the lowest acceptance rates, and similarly with nursing schools. And so we've got to change the paradigm, and we can do that here around expanding those. You know, every medical student costs more money than the extraordinary tuition that they pay. But we've got to have policies, and we can work together on this to be able to keep people here, encourage people that are from here to stay here, right? And so to incentivize that would be a really great way to do it. So I think we could do more work, and I appreciate your comments, and we'll bring that back.
Yeah, I mean, so we did so much last year with tuition reimbursement and loan repayment, that it does, and it is so critical in medical school and nursing school. A big loan can be a detriment to staying in this state for a lot of reasons. So, good. We look forward to working with you on that. Great. Any other questions? One more. Go ahead.
Well, first, a really quick one. Is your wife practicing here? Because we need ophthalmologists.
So she is still practicing in Boston.
Okay.
She's closing up her practice. She's a medical ophthalmologist who's been there in the same practice for 25 years.
Oh,
And
boy.
there's an emotionally wrenching issue, but
Okay.
she wants to see everyone one more time, which is going to make it like 6 months before she stops. But yeah,
I get
she's
that.
on her path. Yeah.
That's hard.
I can empathize with that.
Yeah.
I mean, my husband closed his practice after 45 years and his patients did not want him to go.
Yeah.
I know. I'm
And
sorry.
I think it's mutual, right? They
Yeah.
miss each other.
Oh,
It's
yeah, it was
incredible.
just like, yeah, he's still recovering. Recovering retiree.
Yeah.
Well, whenever she comes, that would be wonderful. So a lot of the issues that Senator Lyons and I have been working on for the couple of years that we've been together, sort of in this room and sort of on the screen. Primary care, and how do we invest more and focus more on primary care. I know you're a specialist, but I really hope that your heart can be in primary care, and how do we tackle that here, because that's a big issue, and our primary care providers are really struggling, frankly. And then opioid use disorder and the opioid crisis has hit Vermont just really badly. And we have an opportunity now with our incoming opioid settlement funds. And I know that you have some people at UVM Medical Center who are experts in opioid treatment. So really hoping you engage in helping solve that crisis, because it's really a crisis. Yeah. And sort of along those lines, but also it broader than that is really engaging with ways to treat and help patients outside of a hospital setting. And you talked about this a little bit, but just as an example, that one thing that Porter has done that is really fabulous is they've worked really hard with our local high school to start a school-based clinic that's been super successful. And it's Porter pediatricians who are there 2 days a week, seeing people in the high school for a variety of things. And it's a fabulous partnership. So really thinking beyond, how do we get out of the hospital into where people really are? And that has been huge during the pandemic for, all the stuff with the pandemic, but also mental health care and sexual health care and just all the things that adolescents are really in the heart of. And that's where they are, they're in school. So that's just one example, but really hoping, I think it would also help with your image problems that the chair mentioned, which are really real, and making sure that UVM Medical Center is seen as somebody who's out in the community throughout the state, not just in Burlington. Mm-hmm. So I think UVM, the college, the university has the same kind of image problem. People see it as, speaking from somebody who's not in Burlington, people see it as a Burlington thing and not a Vermont thing.
I'll just say I agree with all of that. So I think that the primary care piece, we have to do two things or many things. One is that we have to protect our primary care docs, allow them to do what they really want to do, which is care for patients, and take away the other things that they're being required to do and help them with that. And so the EMR, which is the electronic medical record, which is completely the right thing to do for society and for our patients, has been an enormous burden, particularly on our primary care docs. We have to spend the most time on that. So we have to make systems that really help them to do that, which may be other people helping or our automated systems to be helping to do that. And then we have to change the mindset, just going back to being really innovative about the way we deliver care. So doing it in a school is completely logical. How come we don't do more of that? And it doesn't necessarily, and we have to make it easy for people to go do that. So it can't be cumbersome to them to go do that. And then we have to bring other people into that, nurse practitioners, pediatric nurse practitioners, physician assistants, who maybe a day when there's a social worker there who can talk about sexual health and the importance of those kinds of issues for our teenagers. So it doesn't necessarily have to be a doc that does that. Docs have trouble letting go of some of those things, but we have to let them do what their expertise is in, and allow other people to kind of step up and do the work as well, both in the offices and out. And I like the idea we need to do more outside, and that's what we need to do. And people are happy about that.
And one of the bills that we passed between this committee and the education committee last year was a grants program for mental health improvement for kids. And it did include, and a lot of the pediatric practices, VMS was very much engaged in the development of that part of after school, but it did have some of these community connections. And we're going to bring folks in to see how well that grants program did, and maybe there's something more that we can encourage. And that it would be, I know that Porter's very much involved, and I know that other hospitals are, so, yeah.
And we have to allow the reimbursement systems to stay up to encourage that as well.
You
right?
have it right there,
Yeah.
equity across the board. I know it's difficult.
Yeah.
When you have, some practices are being reimbursed better than others. And it's because of their location and volume and everything else. We have a lot to talk about.
Yeah, it's exciting times.
We're just getting started. Any other questions? Anything else you'd like to share with us?
No, I really thank you. Thanks for the time. We, like I said, believe in transparency. I think we can do better about the way we do that. Maybe that's part of the issue when we think about the trust that we have to build is to be by being honest across the network about the challenges that we have and not sugarcoating some of those things. And when we fail, to put that out, and that we're fallible in the way that we work. What I would love is that you would just come to me if you hear about things or see things and allow us the opportunity to look into. And I will be, full disclosure, it's a policy that I think we have in our hospitals. I've had in every hospital that I've brought is full disclosure. That is that when we make a mistake, we tell you as the patient. You can be confident that we will tell you about that. But I want to apply that in the work that we do on a larger scale too, that when we make a mistake, we're going to tell you about that. So if you hear about something, I ask that you come back and we will be honest and tell you that. So give us the opportunity to do that.
Okay.
Thank you for the time. Thank you very much.
Thank you very much.
Yeah.
We appreciate your time.
Thanks.
Ultra wonderful.